Good morning, everyone. My name is Atrisha Sarkar. I'm a postdoctoral fellow at Schwartz Reisman Institute for Technology and Society at the University of Toronto. And on behalf of the Institute, I'm delighted to welcome you to Absolutely Interdisciplinary 2024 for this special event that precedes our main conference. For anyone new to this event, Absolutely Interdisciplinary is SRI's annual academic conference that convenes leading thinkers from a rich variety of fields to engage in conversations that encourage innovation and inspire new insights. Over the coming days, we will come together and advance new ideas through conversation, community, and it's a new word, interdisciplinarity. If you haven't already registered for Absolutely Interdisciplinary, we have an exclusive promo for anyone joining us in person today, which can be used to redeem a complimentary ticket for both days of the conference. Just scan the QR code on display on the digital screens, use the promo code, and register. Today's workshop, Interdisciplinary Dialogues in AI, was organized by this year's cohort of SRI graduate fellows here, and will consist of 4 sessions exploring unsolved challenges in a wide range of disciplines that will be significantly impacted by AI. Before we begin our first session, I'd like to take a moment to acknowledge the land on which the University of Toronto operates. For thousands of years, Toronto has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit Nation. Today, this place is still home to many Indigenous people across the Turtle Island, and we are grateful to have the opportunity to work on this land. So I am assuming everyone here already know about Schwartz Reisman Institute, but in case this is your first time associating with the Institute, I will give a brief introduction. The Schwartz Reisman Institute for Technology and Society's mission is to deepen our knowledge of technologies, societies, and what it means to be human by integrating research across traditional boundaries and building human-centered solutions that really make a difference. We want to make sure that powerful technologies truly make the world a better place and for everyone. A few logistics regarding today's workshop. We are very grateful today to be joined by an online audience, as well as people in the room with us today. Thank you very much. And to those online, thank you for joining us too. All sessions will be recorded and shared online after the event. We will have 2 sessions in the morning, followed by lunch, and 2 sessions in the afternoon. Each session will consist of short talks from speakers, followed by a panel discussion with our invited speakers and Q&A with the audience. During the Q&A, both in-person and online participation will have a chance to pose questions to the panelists. So without further ado, I'd like to introduce today's first session. That is Innovating Care and Interdisciplinary Dialogue on AI and Healthcare, organized by SRI graduate fellows, Joanne Osei-Tuum, Felix Menzi, and Michael Colaci. This session will be moderated by Professor Luke Stark, an assistant professor in the Faculty of Information and Media Studies at Western University, and SRI's inaugural scholar in residence. So the floor is all yours, Luke.
Thank you so much. Thank you, Atrisha. Oh, yeah. Applause, please. Thank you so much, Atrisha. And thank you to the organizers of this fabulous event. I'm looking forward to today. I'm looking forward to the next 2 days of the conference proper, and some great conversations. So I also want to thank Joanne, Felix, and Michael for inviting me to moderate today's first session, Innovating Care, an interdisciplinary dialogue on AI in healthcare. AI in healthcare is anticipated, or AI is anticipated to drastically change healthcare research and the provision of healthcare services. And I have been teaching on this topic for several years, and so I wholeheartedly agree with that. So for this morning's discussion, we have invited 3 speakers to provide real-world examples of AI applications in healthcare, and to talk about some of the opportunities and challenges associated with the use of AI in healthcare. And so I'd like to invite all the speakers to come to the front of the room and take their seats now, please. So I'm excited to introduce the panelists for today's discussion. With us today, we have Mamatha Bhat, a hepatologist and clinician scientist at UHN's Ajmera Transplant Center and an assistant professor in the Department of Medicine at the University of Toronto. She is also a scientist at Toronto General Hospital Research Institute. And Dr. Bhat's work is focused on the use of AI tools and bioinformatics to personalize the care of transplant patients. We have Daniel Buchman, a bioethicist and scientist in education research at the Center for Addiction and Mental Health. He's also an associate professor at the Dalai Lama School of Public Health at the University of Toronto, a member of the U of T's Joint Center for Bioethics, and an affiliate scientist at the Krembil Research Institute at the University Health Network. Dr. Buchman leads a project on big data, artificial intelligence, and implications for stigma, empathy, and compassion in mental health care. And finally, Mohammed Mamdani is the Vice President of Data Science and Advanced Analytics at Unity Health Toronto, and Director of the University of Toronto's Temerty Faculty of Medicine Center for AI, Education, and Research in Medicine. Dr. Mamdani's team bridges advanced analytics with clinical management decision-making to improve healthcare. So today we'll sort of run through the speakers in the order I've just introduced them. Thank you so much for joining us today, everybody. Each of our speakers will give a 10-minute presentation on their research area of expertise, followed by 5 minutes of Q&A. And then after the presentations are finished, we'll transition to a panel discussion with our speakers for about 30 minutes. And at that point, we'll open the discussion up for questions from the audience. So we have about 90 minutes to talk about this topic. And with that, I'd like to introduce our first speaker, Dr. Bhat, and ask her to share a little bit more about her research.
Okay, well, good morning, everyone. It's my pleasure to be with you here today. So I'm a clinician scientist and hepatologist just across the street at Toronto General. And really my research program is inspired by the clinical interactions and clinical experiences that I've had in practice. And I think the very exciting thing is the opportunity to work very closely with computer science professors who've been able to understand the clinical nuances of the questions we deal with in liver transplantation to then optimize equity and outcomes in transplantation. So here are my disclosures. We have received peer-reviewed funding specific to this content from CIHR, NSERC, NFRF, and other sources. So I'll discuss with you some specifically designed AI solutions that have been developed through very close collaboration with computer scientists to leverage interdisciplinarity for equitable outcomes. So there are 2 main themes in liver transplantation that I'll address and I'll get into. So predicting dynamic trajectories on the waitlist to render outcomes more equitable, as well as optimizing post-transplant patient survival. So this is from a review that we published in Journal of Hepatology last year, and really it summarizes the range of applications of AI in liver transplantation. So as a hepatologist, some years ago, as I was still completing my PhD, I was starting to hear quite a bit about AI, and I thought, there's so many patterns that we see in day-to-day practice, and I felt like there was a lot that could be done and with the use of AI to develop AI tools to really kind of replicate that, to understand that complexity for personalized predictions, because this is what I was trying to do subconsciously, and I realized that there were so many patterns in liver disease and transplant that we could really try to simulate and understand, distill in order to generate personalized predictions. So in this particular review, my group, along in collaboration with a colleague from Mayo, we summarized really the potential applications for AI in liver transplantation, looking at identifying suitable donor organs, waitlist prioritization, donor-recipient matching, and prediction of outcomes. And we have some other reviews in this space that I'd invite you to refer to better understand the complexities of questions that we deal with. So I'll dig into some specific examples of how we've leveraged interdisciplinarity to work towards optimal outcomes in transplant. So one important issue, critical issue actually, in liver transplant prioritization is that there are certainly inequities in terms of prioritization of patients on the wait list, as well as subsequently the allocation of organs. And this has been recognized over time. So what we have recognized is that the current prioritization and allocation system unfortunately disadvantages female patients. So they have 15% less chance of attracting an organ offer. Additionally, there are certain subtypes of liver disease that are disadvantaged, specifically primary biliary cholangitis, which is a subtype of liver disease, so cholestatic liver disease. For those of you who understand this term. And then additionally, there's been a shift in the underlying patient cohort over time. So these are three major issues that have resulted in, unfortunately, inequities on the liver transplant waitlist. And I was actually seeing this in day-to-day practice. So unfortunately, I'd witnessed some cases, several cases actually, of patients unfortunately being disadvantaged by this liver transplant prioritization system. And I felt that we needed to do something to address this. And I felt like engaging and working closely with computer science colleagues to develop an AI tool to better prioritize and more equitably prioritize patients would, be a very critical, problem that we needed to address in the liver transplant setting. So this is a project that is now funded by the CIHR, a 5-year grant, and is led by Michael Cooper, who's a PhD student, co-supervised with Rahul Krishnan, who's in the Department of Computer Science, Canada Research Chair there. And so Michael trained a deep ML algorithm, a deep serve algorithm, which he modified. So I'll explain why he did that. So trained on over 53,000 patients listed for liver transplantation in the US since 2016. These were adult patients with decompensated liver disease, and he included 24 static and time varying features per patient. So another interesting thing is that there are dynamics on the wait list. So patients will encounter changes in their clinical condition over time on the wait list, and this is not well reflected by the current prioritization system. So the current model is the Cox-PH model, and what Michael did, having well understood the clinical nuances, so we were having regular discussions around this important clinical question, and he was quite inspired to address this question, having understood the complexities of the question. He actually shadowed me in the clinic to better understand, what patient population we were dealing with this particular project. So he has a very deep understanding of this problem, and with this deep understanding, he then suggested certain modifications to the deep serve algorithm. So to include rates of change in the algorithm to account for changes longitudinally and rapid changes in patient clinical condition, particularly including variables to account for velocity and acceleration in certain laboratory parameters. And by doing this, actually, we achieved a much better concordance. So concordance index, which is the correspondence between rank ordering by risk score and rank ordering by time of death, he was able to achieve a much better concordance index with our new AI algorithm, which is called DynaMeld, in comparison to the current standard of care. And then he looked at fairness, so using a measure called pooled group concordance, where you can determine, how well a certain protected group is prioritized on the wait list as compared to, males on the waiting list. We determined that with this particular DynaMeld, women and those with primary biliary cholangitis, as well as small statured patients, would be much more fairly served by this particular prioritization system. Then he identified what were the ranked features or the variables that were accounting for the prediction by the overall model. But then, so what was reassuring was that the main parameters that are used for prioritization were the top features. However, what was very interesting to note was that there were certain subgroups of patients that actually would have been better served if rate of change had been accounted for in the prioritization. So this was a very interesting and important finding, and in fact, now we can actually provide individualized interpretations. For example, each of these variables has a different weight for an individual patient, and we can actually provide this particular, say, understanding of what it is. What are the factors that are clearly providing this personalized prediction for this particular patient? So the number of points that one would add or subtract based on the weights of each of these features. And so, in fact, now we have interest from both the Canadian prioritization systems across the country. So we have actually engaged all the Canadian liver transplant programs in our CIHR grant to both validate this externally at the other Canadian centers. We've already validated with our own institutional data, and it works very well, so comparably. And now we're doing this in the Canadian setting across the country. But then we also have interest from the UNOS Liver Committee in the US. So there's actually very interesting potential to now deploy this tool at a more international level. So I think what this project illustrates is this, this need for interdisciplinary collaboration in order to develop solutions that will render more equitable outcomes in healthcare. And this is certainly a life and death situation that we are wanting to address, given that 25% of our patients die on the wait list. So we want to make this system as fair as possible so that patients can equitably be served under our system. So now I'll discuss very briefly a paper that we published in Lancet Digital Health. This is also to, say, stratify patients in the long term in terms of their complications post-transplant. So this was a personalized risk calculator for managing long-term transplant care that we're actually now deploying into the clinical setting via EPIC, so our electronic medical record system. This was with Bo Wang, who is at the University Health Network, a computer scientist and CR Canada Research Chair in AI, and then was driven actually by a computer science and a clinical trainee. So I think this is what's critical for any projects, is that you have two trainees who are learning from each other as they drive a project forward. And this is what I've learned. Not only do I learn quite a bit from graduate students and postdoctoral fellows who are wanting to push the boundaries of innovation in terms of methods, new methods for specific clinical questions, but it's quite critical that the computer science trainee learn from the clinical trainee so that both of them drive the project forward and understand the nuances of the question. So anyhow, this was the performance of our model, which we validated in the UHN data set, and now we are actually deploying this tool into the clinical setting. This is another paper that we published in Lancet Digital Health last year, looking at dynamic diagnosis of graft fibrosis. So looking at a long-term complication of liver transplantation. Again, this was a method that was driven by a computer science postdoctoral fellow. So she designed a deep learning model that was further fine-tuned and developed into a new method, which she called weighted long short-term memory network, to increase the training on the cases as opposed to the cohort, as opposed to the controls, to dynamically diagnose graft fibrosis after liver transplantation using longitudinal data. And she incorporated a certain weight loss function in order to optimize that training. And this actually is able to predict very well the presence of advanced fibrosis in liver transplant recipients, which we are now also incorporating into the liver transplant setting. We have the top ranked feature, so this provides interpretability to the model to then say, okay, for this specific patient, these are the potentially modifiable and non-modifiable factors that you can try to address, and also kind of empower your patient in their care so that they understand why it is that they have certain prediction of outcomes. Because in our field, actually, we know that currently the liver transplant recipient median age of survival is 20 years less than the median life expectancy of the Canadian population. So we want to do our best to address this and optimize their long-term care. This is finally another diagnostic tool for graft pathology, and what I want to point out here is this is a multi-class model that was developed again by Divya Sharma to identify the cause of graft injury. So again, you know, as a clinician, I'm constantly looking at patterns and data and clinical and laboratory variables. And so in this particular project, what we wanted to do was to develop an AI tool that could identify what is the cause of graft injury, why is this patient's liver enzymes elevated, and what can we do to treat that particular cause of graft injury. So here she developed a model that was able to determine among 6 large classes of graft injury, she was able to say determine with an AUC of 0.866 using an artificial neural network what was the cause of the graft injury. Now we then examined the performance of this model versus 12 expert hepatologists. In fact, the ML model performed much better, as you can see. So in orange, as compared to 12 expert hepatologists, then what we did was we incorporated this knowledge and we asked the hepatologists to provide a few clinical decision rules that they were that they had in the back of their mind, and we fed those as prior knowledge into the model using some Bayesian inference principles to then optimize the performance of the ML model. And that resulted in a multi-class artificial neural network integrating clinical insight to optimize the performance of the algorithm. So this was incorporating clinical and laboratory variables. So we are actually launching now a silent trial of that particular model as well into the clinical setting. So I think overall the lessons learned in my research program, I think, you know, learning each other's language is essential, and this will happen through close collaboration, and we all have to be willing to learn from each other. I think it's an ongoing learning process. There's so much developments happening in both AI and medicine, and particularly in such a niche, you know, clinical area as liver transplantation. And it's important to help the computer scientists in our collaborations to understand deeply the nuances of clinical questions. And then we have designed here, you know, unique solutions to address those nuances. So I'd like to thank my close collaborators, you know, computer science collaborators without whom this work would not have been possible, especially the trainees who are key to driving this progress, as well as clinical trainees and our funding sources. So thanks so much for your attention, and I look forward to the panel.
I just want to thank the organizers so much for the invitation to speak here today. Really, truly a great honor, and delighted to be on this wonderful panel. So my name is Daniel Buchman, and I'm a bioethicist and scientist at the Center for Addiction and Mental Health here in Toronto, as well as at the Dahlana School of Public Health. And for folks who may not know, the Center for Addiction and Mental Health is a large academic psychiatric hospital. And my program of research there, so I'm both a clinical ethicist but also a scientist, and my program of research focuses on ethics of mental health, substance use, and chronic pain, where they intersect, and more recently focusing a lot more on various forms of AI and looking at themes related to stigma, compassion, and sort of the various sort of ethical issues that these technologies raise. I'm particularly interested in ideas of how healthcare professionals perceive these technologies and how this relates to, as I mentioned, sort of themes of compassion and stigma, but also objectivity and trustworthiness. So I think, it goes without saying, and we know in this room, that there is considerable excitement of improving healthcare delivery and health systems with artificial intelligence and machine learning. In this presentation, I'm going to use the term AI to encompass a broad range of algorithmic systems, including machine learning, deep learning, and where these systems may be both supervised and unsupervised. So proponents suggest that leveraging big data, including genomics, demographic, and environmental information, can improve access, diagnostic accuracy, guide prognostication to help discover new treatments, and provide more efficient and higher quality patient care. So I focus on some of the predictive aspects of these technologies in psychiatry and mental health care as the potential ethical consequences in this context, as many contexts, but particularly here, are not trivial. Some predictions may contribute to unnecessary institutionalization, undermine patients' credibility about their own experiences, and in some extreme cases, contribute to decisions to remove a patient's right to make their own health or treatment decisions. So my focus today is going to be on some of the unintended consequences as it relates to patient testimony. Just acknowledgement, some of the work I'll present here was funded by an AMS Healthcare Fellowship in Compassion and Artificial Intelligence. I want to thank my colleagues at CAMH, as well as my wonderful students and staff in the Everyday Ethics Lab at CAMH. So we're going to start with a case example, and this is something that was published in Wired a couple years ago by Maya Salovitz, and that me and my colleagues adapted in an article we had in the Journal of Medical Ethics a couple years ago. So I'm going to read the case. So a patient named Catherine is undergoing surgery for which postoperative opioid therapy is indicated. A machine learning system built into the jurisdiction's prescription drug monitoring program. So a PDMP is something that is sort of a surveillance tool that sees, for example, where people might access a prescription for controlled substances, where they were prescribed, how much they were prescribed, and other rules around that. And is designed to analyze the risk of opioid use disorder and predicts she is at high risk. The physician is legally required to consult the machine learning system and states they will not provide her with opioid treatment. The patient objects, noting that she has chronic pain secondary to endometriosis, which is greatly ameliorated by opioid medication when needed. She has managed her condition without issue for over a decade, and nothing else helps her pain. The physician knows that the algorithm is widely used in practice, and so the physician assumes that the patient is, quote, drug-seeking and declines to provide an opioid prescription. So this is a real situation, right? We slightly adapted it here, and we're going to return to Catherine's story a bit later. So I think AI and machine learning research has been made important strides towards the potential prediction, diagnosis, and treatment of mental illnesses. But I think, as we all know here, much of the research is still very much in the early stages. And also, these systems are increasingly involved in clinical decision-making processes that do impact the lives of patients in very morally relevant ways. So if AI predictions are considered, or at least hoped for, to produce knowledge that is superior to that of expert clinicians, this means that predictions rank higher on what's called an epistemic hierarchy than other forms of knowledge, such as professional clinical judgment and patient experiential knowledge. Now, these types of power and hierarchies already exist in healthcare. So despite recent efforts over the years towards what we often call patient-centeredness for shared decision-making. So these algorithmic systems may be considered to have more epistemic weight than these other types of forms of knowledge. And as a result, it may enhance the perceived credibility of the AI systems in clinical decision-making and the power and credibility of clinicians and the various institutions who adopt these systems into their workflow. So, as I mentioned, we were very interested in some of these ideas, and we also know some of the effects that it can have on stigma. So we all know, I think, that stigma can have a pernicious effect on the health of already disadvantaged populations. So we wanted to know whether AI and machine learning technologies may similarly influence healthcare professional stigma, empathy, and compassion towards people that are living with a mental health or a substance use disorder. So the objective of our study here was to evaluate whether the description of a machine learning app or brain imaging technology to predict the onset of schizophrenia or an alcohol use disorder, influences healthcare professionals' judgment of stigma, empathy, and compassion. And so participants were randomized to one of these 3 vignettes. So these and only one vignette. And it describes someone named Jane who went to their doctor to say they were worried about developing one of these conditions. And the doctor orders one of the tests. So I'm going to just go through very sort of quickly here. So we found that, and participants who were randomized to these vignettes had answered questions related to stigma and empathy and compassion. And we found that exposure to the machine learning vignette decreased participants' level of anger towards Jane, which was interesting, but it had the detrimental effect of increasing fear relative to the psychosocial vignette. So the psychosocial vignette described was like our control condition, described standard practice. And additionally, we found that exposure to the brain imaging vignette was associated with higher reported feelings of pity relative to both the machine learning and psychosocial vignettes, respectively. And these are important in terms of ideas around the stigma related to people with mental health problems. We also found that exposure to the psychosocial vignette increased healthcare professionals' perception that people are somewhat personally responsible for developing their condition. When compared to both the brain imaging and the machine learning vignettes, healthcare professionals reading the psychosocial language attributed greater personal responsibility to Jane. This could be in part because such assessments often draw heavily on patient self-report and speculation about the relative weights of family history, circumstances, and environmental influences. I'm just in the interest of time, I won't go through them, and our effect sizes, I just will note, were very small to medium. But the interesting thing here on the stigma scales is that certain aspects of the predictive technologies increased aspects of stigma associated with perceptions in the literature, perceptions of technologies that suggest that these conditions are more entrenched and unchangeable and sort of rather not fixed. So perhaps potentially more objective. So despite the goodwill of clinicians, the potential expanded apparatus of AI systems in mental health care may unintentionally create a harm called epistemic injustice, which can intensify the stigma directed towards people living with mental health issues. Epistemic injustice is a type of harm done to individuals or groups regarding their ability to contribute to and benefit from knowledge. So testimonial injustice, which is a type of epistemic injustice, occurs if the reasons a patient's testimony is disregarded are epistemically invalid, such as in the case of unfounded prejudice related to the person's one of their identities. So for example, their gender, perceived racial identities, and other sort of intersecting identities. So people who are living with mental illnesses are particularly vulnerable to testimonial injustice. So for example, stereotypes of people with mental illnesses as being cognitively unreliable or emotionally unstable often encourage others, including clinicians, and there's a very good literature to support this, is to consider their testimonies as irrelevant, confused, or time-consuming. Epistemic injustice does not require clinicians to take patient testimonies at face value, but if a clinician has a valid reason to consider a patient as epistemically untrustworthy, the clinician is entitled to disregard all or some of the patient's testimony. However, some populations are less likely to be taken as seriously as others in belief about their testimony, so it's not applied equitably. So let's return to Catherine, I mean. So in this particular state, in the US, the clinician has a legal obligation and is required to rely on the machine learning built into the prescription drug monitoring program and the potential overconfidence in the algorithmic output. So Catherine was excluded from the decision-making process that is intended to benefit her. Catherine was not only denied access to potential treatment that could have potentially even really helped her pain, but she was not given the opportunity to communicate the relevant information about her condition and having this information recognized and acted upon by her clinician. So in this situation, Catherine's pain was taken less seriously and she was given less credibility about her experiences, not only due potentially to the authoritativeness or the perceived authoritativeness of the machine learning in the clinical decision-making, but it may have also been compounded due to factors, let's say, due to her gender, which is a common and well-documented practice in healthcare and especially in a pain context. And so the possible stigma of a substance use disorder adds further a layer of complexity towards potential prejudicial judgment here. And this may have further downgraded her credibility, the credibility of Catherine's testimony. So why does this matter ethically? Well, the potentially perceived objectivity and accuracy of its predictive technologies may, in some cases, be misleading. Patients may not be given the credibility they deserve, and their testimonies could be discredited because the algorithmic output could be seen as maybe as more trustworthy than the patient. They may also actually displace clinicians from their authoritative position and effectively undermine the shared decision-making process. As a result, this could potentially entrench the notion that people who are living with mental health issues are not credible informants about their experience, could reduce some forms of stigma, such as personal responsibility, and as we saw in our project, simultaneously increase other forms, like fear or perceived dangerous. There could be negative impacts here on the therapeutic alliance, and potentially it could be used to resolve and justify value-laden healthcare decisions that are actually sort of masked as clinical decisions, overriding patients' own testimony. So what do I suggest we think about here pretty critically in the context of this? Well, something called epistemic humility. So I think we need to consider how to balance the anticipated benefits of AI and machine learning in healthcare and psychiatry specifically with the need to promote epistemic humility in clinical judgment. So epistemic humility is a disposition as well as a commitment. It is an acknowledgement that predictive technologies in healthcare, inclusive of psychiatry, are accompanied by limitations of applying scientific knowledge to clinical decision-making, and clinical decisions are tentative and subjected to ongoing revisions based on additional data as well as ongoing contextual considerations. So being epistemically humble requires carefully balancing scientific evidence, clinical judgment, and patient experiential knowledge. So epistemic humility also relates to the belief in the quality of the evidence, namely the scientific processes that produce the evidence leading to the algorithmic output. So this results in a kind of epistemic trust in the algorithmic development itself. So I think, as we're all aware here, there are many concerns that we have about the quality of evidence that are being used to inform AI systems in healthcare, including in psychiatry. This includes the data sets that are used to train the AI, which may also themselves be biased based on the quality of diagnostic labels used to train the system, stigmatizing descriptions in the electronic health record, as well as more severe presentations in underrepresented groups due to upstream barriers in accessing care. So I'm going to leave that there, and thank you all so much.
Great. Do we have any questions from the audience?
It's going to be. I'm just going to describe a case. At our hospital, we had a brilliant internist named Dr. Mo Verma come to us several years ago, and he was very passionate and said, you know, I see patients all the time, and one of the things I struggle with as an internal medicine physician is to help people not die. And that's a very good goal if you're at a hospital, is to help people not die. And we said, how can we help you? And he said, well, you know, we've done an audit on deaths. And what we've realized is that there's quite a few people who die no matter what you're going to do. It's inevitable. They will pass. But there's also quite a few patients, we could have probably done something for them, but we didn't know. So you guys are AI people, right? Can you predict who's going to die so we can help them? And we said, okay, we can give it a go. So what we ended up doing is we created an algorithm called ChartWatch, and we actually saw kind of what's out there in the literature and what other people are using. Like in the UK, they've got something called Muse, which is deployed on over 80% of hospitals in the UK. It's awful. It doesn't perform well at all, and nobody looks at it because clinicians actually know better than the algorithm does. But then we also had to stop and ask, well, how good are clinicians at predicting things like death and ICU transfer and such? It turns out clinicians are not very good at all, but it helps to set the benchmark around how well algorithms need to perform. Because you see a lot around, people will say, well, my algorithm has 98% accuracy, and I can tell you that's utter rubbish because clinicians can be at 99%, right? So you're actually performing worse than clinicians. Whereas another clinical scenario, you can say my algorithm has, let's say, 78% accuracy, and I can say that's amazing because our clinicians are at 52. So it's all relative, right? So anyway, fast forward, we train an algorithm on over 20,000 patients worth of data. We have it predicting in the next 48 hours if somebody's going to die or go to the ICU. We actually deploy it. So we set up a shop that is not a research shop. We set up a shop that actually deploys algorithms. So what the algorithm does is it runs every hour on the hour, again, trained on over 20,000 patients worth of data. We typically have about 120 to 140 different features or so that come into in as information points. So again, every hour it's running, and it predicts if in the next 48 hours if this patient's going to die or go to the ICU. As soon as it reaches a high-risk threshold, it's automated to page the medical team. And our protocols, the medical team should come and see the patient within 2 hours of being paged. And there's all sorts of care pathways, like do you look for signs of sepsis, initiate antibiotics, do you increase monitoring to every 4 hours, and so forth. We deployed this in October of 2020. And so it's been going on for several years now. And we submitted a paper for publication. We've been able to document a 26% reduction in unplanned mortality, right? So these things are actually helping us save lives, which is fantastic. So this is one example of over 50. I'm from Unity Health Toronto. We are composed of 3 centers. The first is St. Michael's Hospital, which is an acute level 1 trauma center, academic teaching hospital, all the bells and whistles in downtown Toronto. On the west end, we've got St. Joseph's, which is a busy community hospital with a large emergency department. And on the east end, we've got Providence Health, which is long-term care rehab. We have over 11,000 staff. We have lots of volume of visits, over 1.6 million ambulatory visits each year, over 350,000 inpatient visits each year, over 170,000 emergency department visits each year. Now, if you multiply that by about 15 years of historical data, that's a lot of data to work with, right? We're the only healthcare organization in the country that has declared AI as a core strategic pillar. We have 9 strategic pillars, 3 of them are core pillars. AI is one of those core pillars. So from the board of directors to the CEO throughout the entire organization, AI is a priority. So I have a team of 30 people. Our whole job is to develop and deploy, not to do research, to develop and deploy AI solutions in clinical practice. And we've developed and deployed over 50 solutions. Interdisciplinary work is key. So we do not work with researchers because that's who we have on our team. We don't work with data scientists. That's who we have on our team. We work with end users, people who struggle with problems day in and day out, the clinicians on the floors, the administrative decision makers. They're the ones who know what the problem is, right? Einstein was quoted as saying, if I had 1 hour to solve a problem, I'd spend 55 minutes understanding the problem and 5 minutes developing the solution. Who better understands the problem than people in it doing the day-to-day? So that's who we work with. They come to our team. Now, our team is composed of 4 different groups. The first group are the techies. You can't do AI without data. But how do you get data out of systems? And again, not research. Research is pretty straightforward, right? You have a nice data set, you de-identify it, you put it onto a static compute environment, you go play for 6 to 12 months, you have a model, and you go publish and give each other high fives. That's not what we wanted. We wanted to do something that was much more applied. So what that means is, if I have to give you predictions every hour, that data's got to be recent to the hour. It can't be 6 months old. So I need a way to be able to get data from source systems that IT folks get really nervous about when you touch in real time. I need to clean it in real time. I needed to feed it to a machine learning algorithm in real time. And I need to get the results out back to the clinicians on the floors all in real time. That is way harder to do. But that's what this team does. It actually grabs data from different source systems, puts into a machine learning operations environment, feeds it to an algorithm, and spits out the results to people who need it at the time they need it. So in this group, you're going to have data engineers, ETL developers, data modelers, and architects, those sorts of folks to do the tech stuff. The second team is composed of our data scientists. Here you have our computer scientists, our operations research engineers, our statisticians. They do the modeling. They'll actually create the model. And I would say 9 out of 10 times, my team would say 10 out of 10 times, research models will not translate. They will not translate to a real environment because a lot of times the data will be way too messy in the real world. You won't have the data that you see in pristine registries. It's really, really messy. But you have to have a research grounding to be able to build those models in a rigorous way. So they build the models. Now the next team is headed up by an artist. Why an artist? Well, he's actually kind of interesting because he went and did a Master of Science in Applied Computing and another Master's in Human Technology Interaction. So his passion is not to develop algorithms, he could, but his passion is how do humans interact with things like AI solutions. So on his team, we have people with expertise in design, human factors, software development, where they create solutions that humans will actually want to interact with. And they understand workflows and the realities of people on the ground when they have a million things on their plate. The last group is our product management and deployment team. Now, this is headed up by an individual with a background in human psychology. Because a lot of what you do when you deploy AI solutions is change behavior, right? And I'm not going to get a data scientist to go in there and understand human psychology and human behavior. I'm going to get a person who understands human psychology and human behavior and is trained in it to actually do things like change management. So she heads up a team that is just focused on education, change management. How do you actually change behavior to be able to take these solutions up in a way that sticks? Yeah. Because these things will be running not just 6 months from now, they'll be running 3 years from now, 5 years from now, 10 years from now. They have to provide value, and people actually they have to want to use them. We have a whole process around responsible implementation of AI in healthcare, and this will be one of my last slides. We do things like bias assessment, but man, these issues are really tricky, and we continue to learn so much. We come from a place where we admit we don't know what we're doing half the time because there aren't many standards. So people will talk about bias assessment, right? I'll just throw something out for maybe the panel discussion later. At what point do you stop? So if I come to you and I say I've done 40 bias assessments on age, sex, marital status, I don't have race data. I didn't do a race assessment. Are you going to stop me from deploying my algorithm? I don't have that data. What if the model is 5% worse performing in a certain race versus another, or 10%? Is that enough? Do you say stop? What are the thresholds? There aren't any. So in a reality where it's messy, you don't have all the answers. Do you deploy? And there are people who will say, how dare you deploy an algorithm without doing a proper race assessment? And my response, they would say, is that ethical? And we actually have an ethicist that we consult with. I would turn back to say, you're absolutely right. We didn't do a race assessment. Let's take down the algorithm and let 26% more people die every year. Is that ethical? So these are the sort of kind of tough issues that we have to deal with when you're actually deploying these sorts of solutions. And of course, there's communication and clinical validation. I think to Dr. Bhat's point around looking at how clinicians perform, that is so absolutely critical. Because when we actually created the ChartWatch algorithm, we had some clinicians say, I need help, I'm not very good at this. We had other clinicians say, I'm amazing, I don't need this AI thing, I'm so good at this. And we said, okay, let's go and see. So we actually spent time on the floors. We spent months doing this. We actually asked our doctors, nurses, and our residents, you just finished rounding on this patient. Don't tell me you know this. You know this patient. You just finished rounding on them. Tell me if they're going to die or go to the ICU during the hospital length of stay. We collected over 3,000 clinician predictions. And we were able to show, and this has been published, that when a doctor says, this patient's going to die or go to the ICU, anybody know how often they're right? Any guess? 80%. Sorry? 80%. They're right less than a third of the time, right? It's hard. It's very hard. If you think about it, like, how are you going to predict if somebody's going to die? It's really, really tough. So what that tells us is the algorithm doesn't have to be perfect. It just has to beat a very low bar, right? So now if you have an algorithm that gets it right 50% of the time, that's still better than less than a third. But it's still going to get it wrong. So this is how we have to educate, we have to train, we have to tell people, don't just rely on the algorithm. You have to rely on your clinical intuition as well. And it's when AI and the clinicians work together, that's when you're going to get the benefit of these solutions. There's also all sorts of discussions around external validation and explainability. People fuss about explainability a lot. I would say it's important, certainly from a research standpoint. But if you really think about it, how much of what we do is without explanation? Some people will argue, do you use Tylenol? How many people here use Tylenol? Can you tell me the mechanism of action? Nobody in the world knows. But you use it. You can't explain it, but you still use it. Why? So similar here, I would say that trust, reliability, reproducibility in an AI algorithm is far more important than explainability in practice. These are sorts of things that you actually start learning when you actually deploy these things around the realities of the messiness of the world. Silent testing, we do quite a bit. Chart watches and silent testing for about a year before we deployed, because we have to learn how well it performs, if the data pipeline fails. And of course, evaluation. We have a fairly rigorous evaluation process where we genuinely want to know if these things work or not. And in some cases, they will not work. So if they don't work, shut it down. Don't spend so many resources on something that keeps going with little to no benefit. And of course, implementation, post-implementation, lots of communication again, and monitoring, evaluation, and maintenance. Our data scientists take call. Why do they take call? Why are they on call 24/7? It's because some of our algorithms are updating every 15 seconds, and they're critical to hospital operations. So if something breaks at 2 a.m., who's going to fix it? Somebody's got to take care of it, right? Your IT folks won't do it because they don't have the skill sets. So your data scientists have to actually take that responsibility. So there's a lot that goes in with so many people from so many different skill sets to be able to pull something like this together. And this is why I was excited about coming to this session around the interdisciplinary nature of what is needed to get these solutions to work. So in brief, I think we need data to make AI work. We need infrastructure. So a lot of technical folks, a lot of people understand data. We need data governance. So people understand governance, who understand ethics and priorities and values. We need data scientists and people who are skilled. We also need good clinical environments. So you can't create these solutions in isolation of a good clinical environment. And I don't think we do enough to integrate clinicians as aggressively as we should. And of course, I would say you need leadership. And one of the most important things that's needed when I am on panels for the federal and provincial governments, we always talk about the tech and how do we get AI. And my feedback to them is one thing if you can do beyond the tech, it doesn't have anything to do with the tech. You have to have courage. You have to have courage to do something different that nobody else is doing. And oftentimes that's the hardest stumbling block. And at that point, I will end and get on to the panel discussion. Thank you.
Okay, are there any specific questions for Dr. Mamdani before we move into the general discussion? Yes, so go ahead.
I have more of a question. When we think about using AI to optimize, and especially where there are trade-offs, so for example, in the case of, let's say there's an organ transplant queue and you need to figure out who should be prioritized and use AI, what do you think that we should be optimizing for? It can be, saving the next person who's going to die, or it can be saving the person who has a higher likelihood of living a long time, or maybe even more scary, it can be, saving the person who has the higher likelihood of having a good quality of life, which can get into really, really tricky issues. So what do you think is the normative foundation that we should be optimizing for?
So specifically in organ transplantation, I would say, we determine candidacy for transplant on the basis that we anticipate that this patient would have success with transplantation, a certain degree of success, likelihood of success. So our bar is 65% 5-year survival by 5 years in liver transplant specifically. Now that threshold varies from one organ transplant group to the other. So there is some degree of subjectivity, I would say, in the decisions that we make around candidacy for transplant. So that in itself is that starting point. So first of all, you have, say, the referrals. So say the physician in the community may choose or not to refer a patient for transplant. And then beyond that, we make decisions around candidacy, which are consensus decisions within our transplant program. But those may vary from one institution to the other. And then finally, there's another, level of randomness in terms of the prioritization of patients. So there are inequities in that prioritization, as I mentioned. So I think overall, we're hoping that bringing in AI solutions will offer the opportunity to bring more objectivity to these decisions as well as prioritization. Now, coming to your question of prioritization on the basis of who would benefit more versus less, we don't prioritize on that basis. We cannot do that. Say, for example, a 70-year-old is on the waiting list versus a 30-year-old, and there's an organ offer that comes up. You would go for who is higher on the waiting list as opposed to deciding whether to allocate the organ on the basis of, say the 30-year-old being more likely to enjoy 30, 40 years of life as opposed to the 70-year-old who may enjoy 5 to 10 years of life at maximum. So we don't, ethically speaking, we cannot assign a certain value to someone's life. So based on the, say, utility-futility argument, but we do have a certain threshold for utility, which is the 65% 5-year survival. I hope that answers your question. So, I mean, overall, we're hoping that AI can bring more objectivity to both candidacy as well as prioritization.
Yeah.
So thank you for the question. I'm just going to build up on some of the stuff that Dr. Bhat just mentioned. So, I mean, I'm a bioethicist, and so I'm biased here. But this is ethics all the way down. Mm-hmm. And I think when we're talking about things like prioritization, or we're even talking about thresholds or tools, as I think you phrased your questions, like what is sort of a normative question, and this is about values. So even if we're saying there's a threshold, that is a value. Or we're making a decision, we're saying, actually, we're not going to use age as a criterion. That is, we're saying it doesn't matter. Or we're trying to balance, let's say, length of life with quality of life. Like those are it's all about values. So this happens, as Dr. Bhat and others know, like in transplant contexts all the time. But I think what's critical as part of the AI integration discussion is that even though we may be striving for more objectivity, which I think is helpful, we can't lose sight of the fact that we're still talking about values. And we're still talking about what matters most, and we're still making normative decisions based on, let's say, quantifiable outcomes. So that's about values. So we're saying this matters more than that, or X is more than Y, or Z is more than A. And I think it's critical as part of those discussions that we're, those teams that are making that decision, those organizations that are making that decision, policies, have some sort of reflection within that saying, okay, why are we making that decision? Why are we choosing this threshold? Why are we saying X matters more than Y? And I think, again, in the spirit of today's meeting, like this is the part of the truly interdisciplinary nature of it that I think we can lose sight of.
Mm-hmm. And in fact, in our project, we have an ethicist, so transplant ethicist, Jed Gross, who's heavily involved in this particular project of the prioritization. I would say, furthering that point, the values of one society will be different from the values of another society. So there are kind of variations in terms of the prioritization in certain countries versus others.
I think this is a great segue, this question, into one of the ones that I had for the panel, right? Which is, in what ways or does the use of AI in healthcare change how you as clinicians or people in public health balance different forms of evidence in decision making? One of the things that we've heard a lot about here are different kinds of evidence, right? Patient judgment, clinical knowledge, statistical knowledge, right? So I'm wondering if, these are longstanding conversations in healthcare. I wonder if AI systems have changed that balance, have affected that kind of epistemic judgment, right, that you're all making, and how you see that going. Also, we start with Dr. Mamdani.
Sure. Maybe not completely long-winded, but a little bit of a long-winded answer. My background is a little bit weird. I started off doing a lot of epidemiology research, pharmacoepidemiology research, and published quite a bit in the area, and was never satisfied with it because there's so many issues with selection bias, confounding, and all sorts of stuff, right? I'm a clinical pharmacist by training, and I did clinical work for about a decade, and I would always struggle with how do I take an observational study with all these biases and apply it to the patient that I'm seeing now? So then I went and I set up a randomized trial center. So I said, randomized trials, that's the way to go, right? How many, on a typical trial, what percentage of patients would you exclude because of your inclusion-exclusion criteria? Any guess? Like 80 to 90% of patients. So as a clinician, I'm sitting there saying, all right, I've got like, let's say 100 patients in front of me. My randomized trial says X, but it's excluded 80 to 90% of the people that are in front of me, and I'm supposed to apply those results. That's insane. But this is evidence-based medicine, right? The other thing I also was struggling with is you got a point estimate from these trials, right? So this one therapy reduces your risk of mortality by 20%, relative risk estimate of 0.8. Great. What about the outliers? What about the people who aren't the average? How do I treat them? And that's where I was struggling with, and we've seen, we actually published a paper in the New England around this actually, where we actually took a randomized trial that was published and took a look at the impacts of how people were actually then changing behavior around prescription, and then the impacts on patients. We were able to show that it actually resulted in harm. The publication of the randomized trial resulted in harm. Why? Because in the actual world, people were actually prescribing these medications to people who shouldn't have been prescribed to begin with because they couldn't remember all the inclusion-exclusion criteria. And you actually see poor outcomes, not better. So this is where AI, I was fascinated with AI to say, well, now there's a tool here which considers the individual patient based on the experience of a lot of other patients to maybe tailor and customize management to that individual. And of course, the proof's in the pudding, and that's why I was obsessed with not the research side, but the application side to say, do they actually make a difference or work? And in 50 plus solutions that we've deployed, I think they're very promising. They have a lot of challenges. They're very promising.
Either of you?
Go ahead.
So I love the questions about evidence, and also I just first want to say I think all our backgrounds are a bit weird, mine included. Definitely not linear. So I love questions about evidence. I teach a course in the Dalhousie School of Public Health called Empirical Approaches in Bioethics, and one of the main questions that we ask is, what is the relationship between evidence and ethics? What does something that's descriptive, like the results of an RCT, does that tell us what we ought to do or what we should do? And so these are age-old questions in philosophy of medicine, philosophy of science. And I think they're really, again, coming to the fore again in AI because of sort of the drive towards, hey, maybe we have a potentially more objective tool that can help us make better decisions. And within that statement, even of itself, is values like better decisions, good decisions, right? Objectivity. So I think when we're talking about evidence, what do we mean? So what kinds of evidence are we talking about? Folks in here might be familiar with the evidence pyramids. There's many different kinds of pyramids. A mentor of mine likes to collect the different types of pyramids because I think they're, you have N of 1 trials at the top and sort of, patient self-report at the bottom, right? So there's these different evidence hierarchies, but I think what matters for evidence is what do we mean by evidence, and what evidence matters most, and for what decisions. So, for example, if I'm, going to my doctor and, and I want to, or I want to know, what COVID vaccine I should get, I'm going to be more interested in the RCTs with all the limitations of RCTs, but I completely sort of agree with all of those issues. I want to look at the RCT data as opposed to a focus group data of whether people liked receiving the vaccine, right? Both are forms of evidence, but one form of evidence in this context matters more. I think in the case I described, which I didn't sort of mention the outcome, which was the person was denied prescription pain medication because of they picked up some opioids for their dog post-surgery, and that got factored into the prescription drug monitoring program, and they were flagged. Anyway, the point being is that in a clinical decision, there are multiple forms of evidence, right? So clinicians have clinical expertise and require on doing sort of the relative tests in order to come to a particular decision. But that knowledge is limited. And it's not the full picture of a patient's context, a patient's history, and a patient's story. Can AI do that? So working together with clinicians, we need other forms of evidence in equilibrium, I would say, sort of epistemic equilibrium, or in some sort of way to integrate and share decision-making that takes experiential knowledge as a form of evidence, as part of that process with what we might get from the algorithmic output and other forms of contextual evidence that we might have. So I think it raises really interesting challenges for shared decision making and what kinds of evidence we're talking about and what evidence we considered matters more than others and for what decisions.
So I can speak from the perspective of transplant medicine, which is very niche. So as I mentioned, I'm a liver specialist, so I take care of patients who are referred for transplant, and then I look after them post-transplant. So I have a practice of 350 liver transplant recipients, and then also, I take care of them throughout that journey, from pre-transplant to post-transplant. So, the issue in our very kind of niche area of medicine is that there's very limited RCT evidence. So a lot of what we do in practice is borrowed from the general population. So say, management of cardiovascular disease or management of cancer is sort of informed by either retrospective observational studies or, some RCT evidence that's taken from the non-transplant patient context. But the reality is that our patients, from the beginning are much sicker going into transplant. They come in with diabetes, with some kidney disease, et cetera. So they're quite different. And then they're exposed to anti-rejection medications. So they have a much higher burden overall of heart disease, of cancer, infection, et cetera. So they're quite a different patient population. So you really cannot apply, say, evidence from an RCT in the non-transplant setting to this particular, specific patient population. So a lot of what we do in transplant medicine is unfortunately informed by retrospective studies, and then people, kind of each one is doing a bit of their own thing based on their own experience. So say I may practice transplant medicine slightly differently from my colleague, who has had a different set of experiences. So, this was actually one inspiration for, say, trying to understand from all the experiences of all hepatologists, all liver specialists, from the US as well as at Canadian institutions, to see how we could make the care a bit more objective of transplant recipients. And I think, there's this opportunity to make the care much more objective. Now, coming on to, say, the patients and shared decision making, say in my research program, we have patient partners who also work closely with us. So we have, I didn't mention this earlier, so we have an ethicist as well as 2 patient partners who are particularly interested in getting involved in AI projects. So they're interested in helping educate the transplant patient community. So we have done sessions with transplant patients from across Canada to educate them. So I've done this in the last few years. But then also we're doing a survey of transplant recipients from across the country to understand how AI tools can best be, say, co-developed and make decisions together, empower them in their health so that they understand what they can do to optimize their own health. So I think that's critical in the longer term, that it not just be, the AI algorithm serving as a co-pilot to the physician in decision making, but also involving our patients, in decision making as well, in certain decisions.
This is a nice segue to another question that I had, which was, and you've already spoken a little bit about this, Dr. Bhat, the process for determining what AI tools will be developed and how are areas of need identified, who are involved, right? Mm-hmm. Maybe if you could add anything more to that question, but also maybe say a little bit about how you've seen or how you expect the AI systems you work with to change the organizational dynamics and behavior once they're inserted into it. There's some interesting work on putting aside the specifics of the algorithm. How does the introduction of something like a algorithm to monitor sepsis in a hospital, how does that sort of change the dynamics of staff, of the social relations? How does that pick up on things like existing inequality or equality? So I wonder if you have any thoughts about that.
So I think one important thing in our field is the need for multi-center efforts. So say I'm actually working closely with people at Mayo. So I did my transplant hepatology training at the Mayo Clinic in Minnesota, and in fact, I have very close collaborations with people at Mayo and the 3 sites. So we're in fact wanting to work very closely together on AI and transplant efforts. I would say we're still, compared to say general medicine, we're still, trying to work our way through these questions, but I think that's where we want to head. So looking at multi-center efforts, across countries, understand how these algorithms work in different environments and how we can improve their performance across different environments. Identify reasons for which these algorithms don't work well in one setting versus the other. Now, in terms of, you're talking about institutional level change, or?
Well, just how these systems might impact, institutions, the organization of institutions, the interactions between staff, patients,
I think overall in healthcare, it's very important for physicians and healthcare workers to understand what is and isn't feasible. So they need to be educated about AI solutions, what AI can and cannot do. And they also need to develop trust in the predictions. So as Dr. Mamdani mentioned, I mean, trust is critical. Now, as you mentioned, with certain predictions, they may be black box predictions, just like we don't know the mechanism of action of Tylenol. So I agree with that. I would also say, though, that in specific decisions, you would like to understand what are the reasons for which that prediction was made. So if I'm going to prioritize a patient higher on the liver transplant wait list, I'd want to understand why it is that this algorithm is doing that as opposed to prioritizing another patient. So this is why I think like interpretability, providing that interpretability for healthcare workers so that they understand why these decisions or these predictions have been made, I think is critical. So education of the healthcare workforce in what AI can and cannot do and its limitations, its challenges is critical. Additionally, I think developing AI solutions that don't increase work burden is also important. Like the environment that I work in is high stress, so like life and death decisions are made constantly. And so we want to ensure that this doesn't end up increasing the work burden of nurses on the ward, but rather alleviates everyone's work burden. So I think that's quite critical, like both education, trust, and engagement of patients, I think overall is important. And then also what Dr. Mamdani has done very well with his group is actually demonstrating the potential for reduced healthcare costs, and that will bring the administration on board as well. So I think those different aspects are critical ultimately for deployment of these tools in a safe manner that also kind of engages the whole healthcare workforse.
I'm going to turn to you, Dr. Mann. You could say more about how you've done this. You've determined what tools to design and seen them integrated. Can you just add to this?
Yeah, I think to Dr. Bhat's point, there's certain outcomes that'll resonate with certain groups, right? So the C-suite will like to see reductions in costs, for example. So in our intake process, we actually have, it's really explicitly laid out. The way the intake process works is anyone can propose an idea, but they have to tell us why it's important. So they can't just walk in and say this problem's huge. You have to give us numbers. Is it a 10%, 20%, 30%? We'll help you get some of those numbers. The next section says, all right, how do you think data and AI are going to help? You don't need to know anything about AI, but how do you think it's going to help you? What are the interventions you're going to put in place as a function of, let's say, something predicting X or Y? Because if you have no interventions, you have no outcomes, right? So it's an academic exercise. So what are you going to do that's different? And then the next section is outcomes. And it asks, what outcomes are you going to change? And it's not a free text box. You have choices. Your choices are 5. Death, readmission, length of stay, human effort, cost. Those are your 5 choices. Now there's another box that says other. If you click other, and that's the only box you click, you're typically deprioritized. So we're pretty clear on the outcomes that we want to hit. Now, it will depend on the organization. Those are the outcomes that we picked. A different organization may pick different outcomes. But those are the ones that people value at our organization. We've tried with patient experience. It's so fuzzy. I don't know how to quantify it or what to do with it. There needs to be work to be done in that space. I'm hoping we can expand those 5. We're not at a point now where justifiably we can, because I have a $5 million annual operating budget I need to justify. And those are the outcomes that justify the operating budget. And of course, the next section is by how much. So when you actually say death, we'll ask you by how much, 10%, 15%, 20%, how much you're going to drop it by. Because when you tell us 10%, that's what we hold you to. So when we deploy, we need to see a 10% drop in mortality. If we don't, we'll sunset the solution. Because there's no point in throwing good money after bad if something isn't working. And so that's how we operate.
Add to that?
I'll just briefly sort of mention 2 points. One is, I think in terms of the overall design and potential design of these systems and implementation, I mean, they're really, and there's some good work being done already in this, is sort of engaging and working directly in that co-design process with the communities that are the intended recipients or beneficiaries of the outcomes, right? There's long, line of work in this in community-based participatory action research, and I think some of the principles can definitely transfer over into this space. And so, it's not only just the clinical expertise and experience in using the technologies, but it's also, what matters most to, these patient communities, right? What kind of outcomes do they want to see with the technologies? How is that being sort of incorporated all over into the design? And then 2, the second point I'll briefly make is just building on what my colleagues are saying. So I take this from Alex John London, who's a philosopher, but also is an ethicist who's done some work in AI. And he's like, the questions that you want to ask yourself are, what is the overall sort of social value of the system you're developing, right? So you want, is the AI system that you're developing going to be better than what currently exists? So is it going to make better decisions than currently exists, or is it going to, even to Dr. Bhatt's point, is it going to increase burden in some way? So he gives sort of a 3 criteria for what he calls the social value of research, right? So is it going to be effective? Is it going to be efficient? And is it going to improve equity? And if you don't meet those conditions, then it may not be something that's worth pursuing.
This is another great transition to maybe the last question I'll ask the panel, and then we'll open it up. Yeah, so we'll just do one more question, then we'll open it up.
Sure. Thank you so much. So I wanted to ask your processes for basically demonstrating or writing out or documenting the ethical considerations or the biases that your models have. But because all of you have somewhat talked about that issue, just wanted to see what is the process that you go about documenting the things that you see that are wrong, the model, or biases that are wrong.
Okay, I guess I'll start first, but I'll go to my colleagues afterwards as well. So this is a really interesting space that is continuing to develop. I think it was Dr. Mamdani pointed to governance models. So I think this is where we're seeing more of it. So at my organization, the Center for Addiction and Mental Health, we're developing our governance models. There's some, we're looking to other organizations like Sick Kids and elsewhere that have started to have this more part of their infrastructure and their research ethics infrastructure. So I think it could look, right now there's no sort of standard, I guess is what I'll say. There's a lot of frameworks that people have put out there. There's a lot of recommendations, and so this is a continuously evolving space. I think maybe a point that I'll make is that often what I've noticed, at least in the literature around AI and ethics, or even in the sort of the operation and deployment of it, is that people will talk a lot about bias and fairness, and sometimes bias and fairness are used interchangeably with ethics. And I actually think they're just one part. So, at CAMH, when we are starting to integrate more bias and fairness assessments into, we're very early days, but we're also intentionally integrating an ethics framework into our deliberative process. And one thing that I've emphasized in our discussions is that ethics is not a checkbox exercise. So you can look at frameworks or fairness assessments or bias assessments are not a checkbox exercise. So it's not as if, did we do this check? Did we do this check? It's actually, it's a basis for interprofessional discussion. It's saying, this doesn't get to the documentation point, but it's sort of the kind of the tools that we're using. So we're saying, okay, so we've given our fairness assessment here. What are some of the implications on power, on equity, on decision making, on consent broadly, on all of these different dimensions, and and we have the people around the table who are various interdisciplinary experts, but also people who are directly impacted by those decisions.
I was going to ask a question about valuation, so this is totally backs this up. Maybe, Dr. Bhat, Dr. Mamdani, do you want to add about this question about specifically about documentation, or maybe more broadly about evaluation of these systems in Ontario and how that's done? How, what is the governance of AI in clinical settings?
I just wanted to expand a bit on the bias angle. So I think we have to be careful, just expanding on this further, that as we try to rectify a bias, that it doesn't disadvantage those who were initially over-advantaged. So we want to be very cautious about that. So for example, in our Dynameld model, which I described for the prioritization, we also did assess how patients are reclassified. So beyond the fairness measure, which I was referring to, say the pooled group concordance index, we also wanted to assess how different subgroups of patients were reclassified. And then we simulated the impact on, say, deaths, so organ allocation and deaths of our prioritization system, of our new prioritization system. And fortunately, the reclassification we anticipate would not, say, adversely affect those who are currently being over-advantaged, because they could actually wait longer for an organ offer to become available. Now, that's the prediction. How this actually works out, prospectively is a different question. Now, in our field, in the liver transplant field, I would say that the prioritization scores that have been developed in the past were just, trained on retrospective data and then immediately implemented. So there was no, say, silent trial or silent testing, nothing. They just went ahead because it was seen that these prioritization scores would be an improvement, would represent an improvement upon the status quo. The status quo was actually very poor. So overall, these systems have decreased waitlist mortality as a whole. And now I think what we want to do is, do our best to address any biases that have been identified and try to render this as equitable as possible for the overall patient population. Now, how this plays out is, is going to be exciting, I think, as I said, both the US as well as the Canadian liver transplant prioritization committees are interested in our model, and, we're working with them to, work towards deployment of this tool.
See what evaluation, and then we'll open on to a general discussion.
Sure. I think to Dr. Buchman's point, it's tough to make it a checklist. We kind of have made it a checklist, but at the end of the day, the decision is not going to be based on a checklist. So, for example, I think, Dr. Kalaki, you're presenting, is it the bias thing that you're presenting at SAIL?
Yes.
Yeah, okay, so for ChartWatch, we actually did do bias assessments. There's over 20 parameters or so that we looked at. So we do actually have a bit of a list around the things that we go through, for example, age. We look at sex, we look at sickness, like sick, not so sick. There's social deprivation that we try to get at through surrogate measures and such. So we try to do the best we can. And it sounds wonderful, but it is messy. It's incredibly messy. Because depending on the nature of the initiative, you may not have enough numbers to actually do appropriate assessments of bias. So you're kind of stuck with the sample that you have. In other cases, we'd love to look at things like, there's over 100 genders, right? If we start cutting in terms of model performance within genders, first of all, we don't have gender data. But secondly, you're going to get unreliable, unstable estimates of bias. And then there's the judgment call of, okay, well, what number are you getting, and is it acceptable or not acceptable? So it ends up being a discussion to say, have we done enough? Does it seem reasonable? Do we have a go, no-go decision?
Good. Okay, I think we are now very pleased in the last 11 minutes and 30 seconds to move into our question and answer period and welcome more questions from the room. For those in the room, please raise your hand and ask a question and speak clearly so that your contribution is captured by the mics in the room, the ambient mics, and can be heard by those folks online. For folks online, you're welcome to type your questions into the chat, and a member of our moderation team will convey them to the speakers. So are there any questions in the room, first off? Yeah, over there, I saw the first.
So I have a question across the panel. So essentially, what are the risks of privacy/privacy violation considerations that you made in your work, and would it be possible to share some of the implications at an individual or group level?
I can cover it.
One
Okay.
or each or all?
So for our projects, we don't ask for consent. This might really surprise me. We don't go for individual level patient consent. It's just impractical. So if you walk into our hospitals, you'll see actually signs in places saying that we are using your data for quality improvement. I don't know if we use the words AI per se, but for these sorts of purposes. So we have developed our program under a QI framework. So in terms of privacy and security, we do access data as a lot of QI initiatives would. Everything we do is on-prem, so it's behind our firewalls. So whatever is the security and privacy protocols of the hospital is what we adhere to. So for us, we're not really subject to a lot of the kind of research grade requirements of consent, de-identification, and all that sort of stuff. Our team is one of two teams in the hospital that has access to very sensitive data, because our argument has been, if we tell you patient 14728 is at risk of dying in the next 48 hours, it doesn't do anyone any good. We need to know it's Mr. Jones on bed 2 and 14 Cardinal Carter on this unit, right? So we've allowed for those in our data governance framework. We've allowed for those permissions.
I'll just say that I would expect the normal rules and regulations and laws around privacy applies, but I guess I will just say from an ethics perspective, the potential implications of a privacy breach might be disproportionately burdened on more disadvantaged populations. So the negative outcomes of a breach that people, who are not as socially advantaged in various sort of intersecting respects, they might have worse outcomes should a breach occur. So I think it's critical that institutions have these very sort of strong, robust systems in place in order to uphold both that legal and moral duty.
Yeah, so I would agree, and in fact, for our training and testing, I mean, these are all, say, retrospective data that we trained on. So we have research ethics board approval for working with the de-identified data obtained from our electronic medical record system. And in terms of the deployment, so, as Dr. Mamdani said, so we're deploying under the framework of QI, because as it stands, everyone is, as I said, doing a bit of their own thing in transplant medicine. So we want to, improve upon that by making, personalized predictions to improve patient care. And so we are deploying under the QI framework. So there isn't any question of consent being obtained for these studies.
Let's go to online. Are there any questions in the chat?
You had a question I noted for a little while. I don't know if
Sure.
I can get to one of the online afterwards.
Sure, yeah, go ahead. Then we'll go online.
Lawyer, don't throw things. So I have about war, so like death decisions, kind of similar, accountability, even decision making, a big issue around trust in AI. So just wondering how you get, doctors who are liable for like death decisions to trust the AI when so long we've been relying on their experiences as clinicians and making decisions. Because as we'll talk about in the next panel, accountability for use of these things is one of the big gaps in the laws of work context? I'm just kind of wondering how it works in the notes.
Yeah, so I think in my field, as I mentioned, we make certain decisions as consensus decisions, so they're committee decisions, whereas other decisions are made in day-to-day practice. And the reality is that most physicians are still overall skeptical, whether it's in transplant or in medicine in general. Most physicians are still very skeptical of incorporating AI tools into their clinical practice. Whether you're talking to physicians in the US or Canada or internationally, this is very true for a significant proportion of physicians. There are others who are quite enthusiastic and interested, excited by the possibility of AI tools. And then there are others who are a bit more neutral. So I think overall there's a great deal of education that is necessary, not just a superficial understanding, but a deeper understanding of what is or isn't feasible. And then bringing trust is going to be feasible if they understand why certain predictions were made, as I mentioned earlier. So now another concern that many physicians have, if you survey physicians on AI, they're worried, especially in certain specialties, about AI kind of taking over their tasks. But the reality is that I think there's so many subtleties in the practice of medicine that I only see AI as a co-pilot rather than a driver of decision making, because the decisions are so complex in life and death, and there are medical legal implications to the decisions that we make, that we want to be absolutely certain that a prediction that is made by an AI tool won't result in harm as opposed to benefit. So I think we're still early days in many fields of medicine in terms of the deployment of AI tools and making sure that they're safe enough for day-to-day use. And I think that will come with education and trust building among physicians as well as patients. So patients also have to advocate for implementation of these tools, and they also need to understand the benefits and limitations.
I'll sort of quickly make a conceptual point in that I think we often talk about trust in the systems, but I think it's a misnomer. I think it's actually more of reliance is the proper term. We trust human beings to do what they say they're going to do and act for our benefit. We more like, I don't like trust my bike to get up the hill. I rely on it to do so. But I also worry about questions about how do we get clinicians to trust AI. And I think I worry about the way the framing of the questions too, because I see it also even with patients, like how do we get patients to trust doctors? And when we trust, we make ourselves vulnerable. And that may be one of the reasons why clinicians are feeling sort of a bit uneasy about relying heavily or placing their confidence in AI systems. So I think what matters is that it's not that how do we get them to trust, it's that how are the designers, the people who are implementing it, demonstrating trustworthiness? How are they demonstrating the virtues of the character traits that are necessary for clinicians to, I'm going to use the term trust here, to place trust in the systems? So, and if you look at scholars of trust, there's different types of trust, and so we're talking about like epistemic trust. So we're talking about in the trust in the quality of the data that was used to train the algorithm. We're talking about trust in the process of design. We're talking about trust in the institution, in all of these different levels. So it's from my perspective, it's multi-leveled. And so I think that in order to maybe buy-in is a better term, but in order to have people use it in a way that it's intended, I think a lot of the trustworthiness demonstration needs to happen in multiple sort of domains so clinicians can feel confident. Other than that, in some US states, like with PDMPs, there's a legal requirement to consult the PDMP in order to make a clinical decision, let's say around a controlled substance. So there's almost a forced trust there, which I think is concerning from an ethics perspective.
I want us to go to the question online quickly in our last 2 minutes.
So I'll just summarize here, but the question online is, in trying to deploy these tools,
Are there new roles that are needed? I know you talked about some of the interdisciplinary teams, but with increasing deployment of AI tools, are there new roles that are needed to sort of facilitate?
Dr. Mamdani, why don't you start with that?
Yeah, sure. I think in terms of actual deployment, let's assume that you've actually created the solution and that you've got all sorts of design and all those sorts of people in place. I think people who understand change management and behavior modification become really important. Because at the end of the day, a lot of these solutions, I don't see the majority of them being automated solutions. I see them as being support solutions. So they actually have to work with people, and they're going to make mistakes. So how do you take a solution that is imperfect, apply it to a practice setting that is also imperfect, where people are going to say, I don't really believe one or the other. And so understanding behavioral economics, change management, those sorts of things I think will become increasingly important in AI adoption.
Yeah, so I would completely agree with that. And another aspect that's important to consider and we didn't cover is, say, assessing for drift. So changes in the algorithm performance over time based on changing dynamics in the patient population. So I think that's actually critical. Assessing for any changes in performance, any new biases that are arising. I think those people, like say the analysts and data engineers who understand and work closely with clinicians to understand what are the reasons for drift over time, and then fixing or fine-tuning the algorithm to improve its performance as the data changes over time, I think is critical.
I know there were other questions, but I'm afraid we are now out of time. We could have talked for hours, and I think that's a testament to both the importance of the topic and also the excellence of the panelists. So please join me in thanking the panelists very much.